Having reached the point of considering what's on a differential diagnosis list, we then have to find some way of moving forward from that point. And what expert clinicians do under these circumstances is to compare and contrast the constellation of signs and symptoms that they're considering. It appears that experts have memorized elements of medical conditions and organized them in their heads to allow them to make these comparisons. So in this part of the presentation, we're going to look into the structure of how this is done and how paramedics might recreate this. So, how do we move from the current level of knowledge towards a more expert process? So research has proven that experts have memorized packets of information, these encapsulated areas that they know about particular conditions, and they readily recognize the epidemiology, the timeline, the clinical presentation, and the pathophysiology that's associated with each of these conditions. Experts develop a compare and contrast system between one disease and another using the same 4 quadrants every time. So, despite many conditions sharing some common characteristics, they can winnow their way through this information to recognize the differentiating factors that make one diagnosis more probable than another. Developing this ability is a 2-phase process, and the first phase starts with learning individual illness scripts. The second phase is to group these illness scripts around a presenting complaint or syndrome. In this session, we're going to investigate the knowledge associated with phase 1 of this. So let's have a look at how an illness script works. Essentially, it has 4 discrete areas of knowledge for every condition. The first is knowing who gets the disease. This is the area of knowledge that we call epidemiology. The second piece of information is the time course that the disease presents over, i.e. acute versus chronic. The third are the signs and symptoms and the test results that are typical of any given condition. And lastly, and to some extent, we fuse these 3 areas around knowing what went wrong before and during the illness. In other words, the pathophysiology associated with it. So let's go on to look at epidemiology. This is the branch of medicine which deals with the incidence, the distribution, and the possible control of diseases and other factors that relate to health. But for a simpler explanation, epidemiology indicates who might get an illness or an injury. So when we write up the epidemiology of an illness script, we seek the classic demographic representation, which would normally encompass the age group, the gender, and sometimes, but not always, ethnicity. Additionally, when we investigate demographics, we need to look into very specific risk factors, such as the existence of other pathology, which is going to make the condition more likely to have occurred. Lastly, this section is going to investigate the particular routes of exposure that might come from travel, maybe occupation, residential factors, or lifestyle activities maybe that would include things like drug use or perhaps even sexual orientation that are associated with a specific disease. By way of an example, let's look at the epidemiology for community-acquired pneumonia. In terms of demographics, it appears that anybody could get a community-acquired pneumonia, but really 30% of the people with this condition are quite often 75 years or older. It is slightly more prevalent in women than it is in men, but not to the extent that it will become a distinguishing characteristic of the disease. And there do not appear to be any specific ethnic predisposition towards getting a community-acquired pneumonia. In terms of risk factors in this quadrant, we know that people that have other pathology, and particularly if they have serious lung disease such as COPD, and if this is associated with long-term steroid therapy, they're more likely to contract a community-acquired pneumonia. And there are no specific exposures for a community-acquired pneumonia. It may be slightly more prevalent in households that are a bit more crowded, but at the end of the day, this doesn't seem to be a distinguishing factor. So a timeline that ends up on an illness script may reveal a chronic condition that's been there for more than 3 months, or in many cases for years. However, it might also be subacute. That is a condition that doesn't have symptoms that have really impacted on the patient in any significant way. The alternative scripts might include an acute episode that has developed over the previous days or weeks, or it may be hyperacute and that has developed over the last few minutes or hours. Now, these timeframes are not set in stone. They can, in fact, differ slightly from condition to condition, but a tremendously helpful clinical pearl is to ensure that you've written down timeframes in objective terms. That is the number of months, the number of weeks, days, minutes or hours, rather than trying to compress it into one of these terms such as chronic or subacute. We'll use the terms as a form of shorthand in the template, but the illness script itself should contain the more subjective description. When developing the illness script, the timeline becomes an essential factor. From your lectures last year, that you recall the basis of examining the history of a primary complaint can be based on the mnemonic OPQRST or an equivalent such as Socrates. In either model, when you're reviewing the T factor, that is the timing of the history, there are some specific features that you need to include when you're constructing the script. Most scripts are going to show one of two particular patterns. Firstly, that the problem is constant in nature, or secondly, that it comes and goes. If it is constant, the script should also include whether it's likely to worsen or improve over time, and whether or not a particular time or an event triggers the symptoms. This is equally important when the symptom is intermittent, and the other thing we need to look for is whether there's some biphasic pattern to the symptoms. Now, biphasic patterns tend to come in one of two types. The first is a timeline of the symptom being interrupted by symptomless episodes. So you might think of asthma in this way. The second type is where there's some background symptoms that are constant in nature, but they are punctuated by episodes that are much worse. So those might be a background chest pain that's worsened when somebody coughs. Again, let us use community-acquired pneumonia as an example to see what this timeline will look like if we put it into an illness script. So the onset normally has a prodrome of upper respiratory tract infections, such as a cough, rhinorrhea, sore throat, fever, etc. Over a period of many hours, but more likely days, more localized symptoms might occur, such as pain with coughing. Some symptoms may be biphasic in nature, that there's a constant background symptom, such as the pain, but this is going to worsen with respiratory movement and cough. And the same might be true of any shortness of breath that's reported with us, which will often worsen when the patient is lying down. And overall, there's likely to be a steady progression of worsening of symptoms with the passage of time. From timeline, we move on to the third area of discrete knowledge, which is clinical presentation. So essentially, these are the signs and symptoms or any test results that are normally related with a particular disease. Now, you've already got some of the tools, such as the OPQRST process, a vital signs survey, and the like to assist with this. The illness script itself presents the classical signs and symptoms that we're going to associate with a specific condition. We can break these classic symptoms down into two groups. The first are the general features of the disease. And for this group, if we were going to use community-acquired pneumonia as an example, we'd be looking at cough and fever. But these symptoms are likely to present for other respiratory presentations that don't really differentiate between one disease and another. So the second set of signs is known as differentiating signs. And these are the signs that are less general and may be slightly more specific to a fewer number of conditions. For instance, coming back to community-acquired pneumonia, this often progresses to symptoms that will include a unilateral wheeze and localized consolidation that could be elicited with auscultation and percussion. Now, there are two subsets to these differentiating symptoms. The first is the must-have or the confirming symptoms. In other words, a feature that has to be present for the condition to be there. For example, no fever reduces the probability of it being a community-acquired pneumonia. In other words, fever really has to be there. The second subset is the rejecting features. Now this will tell you, if it's present, will tell you that an illness isn't there. Now it'd be brilliant if there were a list of these for every condition, but unfortunately they are very, very rare. And generally speaking, you're going to be left to sift through all the other differentiating features to determine the most likely diagnosis. So the signs that are associated with the early stages of a community-acquired pneumonia are fever, which may be experienced as chills or sweating, but you'll be able to pick it up with a thermometer. Cough, and normally a productive cough with a thicker mucus. There'll be a mild tachycardia, tachypnea, which is our increased respiratory rate, and quite often there'll be localized crackles on chest auscultation. As the condition worsens, there becomes a marked tachycardia and marked tachypnea. A wheeze will develop, and we get consolidation, which is identified very readily by regional dullness on percussion and very loud bronchial breath sounds over the area that's consolidating. And as the condition worsens again, we can get confusion and shock. These signs and symptoms won't only just help with differentiating the disease itself, but they can help knowing at what point referral should be made. So referral is made using a score system known as the CRB score, and if this score should get to a level of 1 and no red flags exist, then paramedics can make an immediate referral into primary care for management with antibiotics. However, if the score is greater than 1 or a red flag is present, it would be most appropriate for a strong recommendation to get the patient to an ED. So the CRB score has 4 elements. So the first is for confusion, and if that's present, the patient scores 1. The second is respiratory rate, and a rate of over 30 a minute will score 1. And if there are signs of shock, and this is also a red flag, the patient will score 1. And for patients that are greater than 65 years of age, if this is true, they also score 1. So we have a very low threshold for referring people with community-acquired pneumonia onto either primary health care, if there's this moderate score of 1, or if there's a red flag and a score greater than 1, straight to ED to get it sorted, because quite often it requires the empirical use of strong antibiotics to overcome this condition. In the diagnosis, the test that's normally performed to confirm that it's pneumonia would be a chest x-ray, and hence EDs are a great location to have this done. The final area of knowledge we're looking at is pathophysiology. Pathophysiology describes the changes that accompany a particular syndrome or disease. Or you might want to just say it does describe the changes occurring as a result of a disease or a condition. We'll continue our view of community-acquired pneumonia, which is most likely to be caused by the aspiration of pathogens from a person-to-person contact. It's less likely to be due to aerosol conditions such as, say, air conditioning, but this might happen. The pathogens enter via the nose and they colonize the upper airway, and so there they might produce some respiratory tract infection type symptoms. But they will also proceed to the lungs via microaspiration. The pathogens will continue to replicate in the lung, and eventually there they'll overcome the immune system and they'll create an infection within the architecture of the lung tissue itself. This infection is likely to result in inflammation, and if this is not overcome by the immune system, we end up with a secondary colonization by these microbes. Clinicians can link the pathophysiology to the classical presentation, and in this case, the presence of a pathogenic bacteria has caused an inflammatory response and hence the fever. The infection and the white blood cell response cause significant debris to form, and this forms mucus, which in turn is going to irritate the airways. The irritation produces the cough, and of course the mucus is going to be brought up as the thick sputum that we see with this. Secondary bacterial infections can cause the sputum to become coloured, another common feature in community-acquired pneumonias. The inflammation also results in an exudate being formed. Now, this is a serous fluid that can consolidate within the lung. The consolidation will produce dull sounds on percussion and allow for the amplified transmission of bronchial breath sounds. In other words, they sound a heck of a lot louder over the area that's consolidated. And the severest presentations of community-acquired pneumonia are associated with sepsis, or in other words, the fact that the infection is no longer regionalised but has entered the bloodstream. This is going to produce systemic signs, including confusion and shock. The similarity between a novice and an expert is that they both initially learned the illness script from textbooks. However, experts have gone on to use their experience in dealing with these conditions to shape and refine their knowledge. It might mean that no two experts have precisely the same illness script for a disease. Still, you could bet your last dollar that the foundation of their understanding has come from some targeted study into the epidemiology, the typical timeline, classical presentation, and pathophysiology of each of these diseases. So, to assess diagnostic skills, we will need to examine the rationale behind the diagnostic decision-making. We're examining the process of accessing differential diagnosis lists and linking these to the four elements of the illness script. The classroom sessions will be dedicated to the development of these illness scripts. And for this exercise, we will focus on the scripts associated with acute respiratory problems and the pulmonary causes for shortness of breath. We're providing a template, and the expectation is that you will research and present a comprehensive illness script for these conditions. The activity should prime you to be able to do this for any condition and continue to develop these packets of information to assist in your rationalisation and the use of the differential list for working diagnoses. In the meantime, here's my collated illness script for a community-acquired pneumonia. You'll be able to access this in the notes that are with the presentation, and in the meantime, ka kite.